Good afternoon, everybody, and thanks for having me here. As he said, my name is Dr. Bruce Williams. I'm a family physician here in Blue Springs. I work at Family Care of Eastern Jackson County, which is part of the HCA network. And there's multiple HCA primary care practices in Eastern Jackson County, Lee Summit, all around the city, really. Our network is about 300 and some physicians. We need to take into account all the primary care physicians as well as specialists. I'm a graduate of Kansas City University of Medicine and Biosciences College of Osteopathic Medicine. That's a mouthful, I know, and it's undergone several changes in their name even since I graduated. It was the University of Health Sciences when I was going there. So if any of you remember University Hospital, maybe some of you were born there. That's where I did my internship there at Parkway Medical Center in Raytown that has since closed, and now it's River Refuge. So it's actually doing some good things to help with the homeless population. So I did my internship there, and I started my practice in Independence in 1988. Moved to Blue Springs and went into practice with Dr. Keith Broughton. Maybe some of you went to him, or maybe he delivered some of you. But I was in practice with him for about 5 years before he retired, and our office has moved to a couple different places since then. One of the things I want to start talking about is some of the challenges that people have with trying to find a primary care physician. And I want to address those first because I know those are all questions and comments that are going to come up, so I want to try to get those out of the way. The first one that people are always going to say about is it takes so long to get in to see a primary care physician. And that's true, and that's a challenge that we're trying to deal with. And the reason that's the case is, one is there's a lack of us. We're really struggling to try to find primary care physicians now that want to do ambulatory medicine. So a couple of reasons for that are there's a perception among medical students, and this is Rich, he's working with me this month, that you can't make any money as a primary care physician. And that's not true. I'm doing fine. I live a comfortable life, so that's not the case. A lot of the physicians that are coming out of medical school now to become primary care physicians are going into hospital medicine. They're becoming hospitalists instead of going in and becoming community physicians. So it's a struggle trying to find primary care providers to come into our practices. So as a result, we're having to hire more and more nurse practitioners, which isn't a bad thing. I actually have an excellent nurse practitioner that works with me right now. But that's been some of the challenge. The other challenge is our ranks are aging. So I'm about ready to turn 60, and retirement's definitely in my windshield, and that's becoming more and more the case. So as primary care physicians that are practicing are aging and retiring, there isn't a lot of physicians coming in to backfill those positions. So that's left kind of a void. The other challenge is electronic medical records. So in 2010, our practice went on to the electronic medical records. It was about the time that a lot of the practices started doing electronic medical records. At that time, I could see about 35 patients a day. After we went on the electronic medical records, I could only see about 25, and it was killing me to do that. So that has really cut down the amount of volume that we've been able to get into our offices, and it's been a challenge. So what are we trying to do to address some of those things? First of all, to try to replace the primary care manpower shortage is a lot of the organizations, the American College of Osteopathic Family Physicians, which I am actually on the board for, I'm the Secretary-Treasurer currently, the American Academy of Family Physicians, and all the other family physician groups have started a initiative, a steering committee called 25 by 2030. So their goal is to have 25% of the healthcare workforce be primary care physicians by the year 2030. That's 25% of all the physicians. Right now, it's about 8. So we've got some heavy lifting to do.
Yeah.
And some of the things that we're trying to do now is we're trying to actually approach high school students, college students, and even medical school faculty and leaders to, really try to reinforce the need for primary care, for students to go into primary care. Now in osteopathic medicine, we're actually already at the 25% mark, or actually it's more like 23%. So we don't have as big a jump to make, but osteopathic medicine has traditionally been primary care, family physicians and internal medicine. So primary care is family medicine, internal medicine, pediatrics, and some people throw OBGYN in that group as well. So, there are some things that we're trying to do that way. We're also trying to work with Congress. So one of the problems that we have in Congress is that in 1997 they put a moratorium on the amount of residencies that could be established in the country. And as a result, there's a huge competition for residency spots. In fact, there's more medical students coming out of school than there are residencies available for them. So one of the things that we're trying to do is establish more residency programs. And there's been 2 that have opened recently in Kansas City, an internal medicine and a surgery residency in HCA hospitals. And there's going to be an OBGYN residency starting this coming year, hopefully. And we already have a family medicine program, so they're trying to do their part to improve the situation. But we need more residency programs. So one of the things that we're trying to do with Congress is get them to lift that moratorium so that there can be more money available for residency programs to start. It costs about $100,000 to fund a resident. By the time you provide them salary, their benefits, because you have to pay them health, and you have to pay them their malpractice, and you have to pay all those expenses. That's pretty much what it costs. So there is an expense involved with just don't open up a residency program and say, okay, here we are, we've got all these residents coming in. So one of the initiatives that we're trying is the rural training program. So osteopathic medicine has always been typically a community-based profession. So our training programs have been in rural and community hospitals, whereas the MDs have been more in academic centers. So if you look at where I trained at University Hospital Park Lane, it's more in the community areas, smaller community hospitals versus University of Kansas, Truman, where the MDs traditionally train. Next year, all the training programs are going to mix together. So the osteopathic physicians and the MDs are all going to be trained in similar, and they're all going to be under what they call the ACGME, which is the Accredited Council for Graduate Medical Education. And they're all going to kind of be under the same rules and everything. So they're trying to bring us more into the academic realm, and we're trying to bring them more into the community-based realm as far as training. We're trying to get Congress to buy into that so that we can ease up that issue with the lack of physicians. As far as electronic medical records, I know all of you who have primary care physicians, or even if you go to an urgent care center, or if you go to even the ER or in the hospital, one thing you really don't like is your healthcare provider staring at the computer while they're trying to take care of you. We don't like it either, but the reality is you got to document stuff. So there's some legislation pending in Congress now. It's called Patients Over Paperwork, where they're trying to make the documentation burden less for the physicians, so that we actually get to spend more time with patients. There's some issues with that, but at least the discussions are starting in that area, so that hopefully in the future I can spend more time looking at you and talking to you than I am documenting the computer. A lot of us work around that. Personally, I don't like staring at my computer when I'm in with a patient. I try to do most of my documentation either beforehand, look up their labs and all that kind of stuff, or you have to do it afterwards, which means when we get done at the end of the day with seeing our patients, we get to go home and do all our documentation. So that's really frustrating physicians. It's contributing to burnout. It's contributing to physicians retiring early, and even our staff. So, I think there's some things in the work that are going to make things better as far as the challenges that we're facing right now. Hopefully we're going to be able to do our job with this 25 by 2030 and incentivize more of these guys to go into primary care and ambulatory primary care, not just become hospitalists. The attraction for the hospitalists is that they work 4 days a week. They work, like 12-hour shifts, and then they get a few days off, and everybody wants to spend more time with their families, and it's not a hard toss to see where that would be attractive. So, but we still need people in our offices too. So, hopefully we're going to be able to find a way to attract more of those physicians in. I think we will. I think we've got a good group of people that
Is it because specialists have such a higher pay rate, or is there better compensation from Medicaid, Medicare insurance companies for specialists, or is that where the doctors are going instead of?
A lot of it is the perception of better compensation.
Mm-hmm.
You have to remember that when these guys are coming out of medical school now, their student loan debt is close to $500,000. That's and they're seeing that. It's like when am I going to pay this off? And it's they're like then I have to spend another 5 to 6 years in a residency program where that's going to get delayed even more, and the interest gets tacked on and all that kind of thing. So they're looking at some of the economics of what they're doing. They want to get those student loans paid off. So they're looking at cardiology, they're looking at neurosurgery, they're looking at anesthesiology, they're looking at radiology. Some of the higher paying specialties. They're also a lot more of the competitive specialties. But these kids are smart. The president of his medical school, which is also my medical school, currently says, well, I can be your president, I couldn't be your classmate, because he was actually turned down to get into our school back in the 1980s. And I feel the same way. There's no way that I'd be able to get into that school just because of the competitive nature of the students that are coming in. So these are really smart kids. I mean, when they talk about the top 1%, you're looking at it right there. And I mean, these are sharp kids. So they're very competitive, and they're going to go out and get those residencies. Doesn't mean that the family physicians are any less competitive. The person who graduated #1 in my class practices over here in Lee Summit, and #2 practices up north. So they're both, one's an internal medicine and the other one's family physician. So I always wanted to be a family physician. I never really wanted to do anything but. It was in fact, I wanted to be a family physician before I wanted to be an osteopathic physician. When I started learning about osteopathic medicine, I'll get into that here in a few minutes. I ended up only applying to osteopathic medical schools, but my desire, even my parents told me when I was about 4 years old, I started talking about being a doctor, and the family doctor was the only thing I wanted to be. So it's not that doctors that go into family medicine are any less knowledgeable than anybody else. It's that a lot of them are looking at the economics of what's going on. So.
To me, it almost, when I listen to my different consumer base, there's a different level of compassion there too, from when they go to a family physician versus a specialist. Where a family physician, they feel they kind of look at the whole person, versus the specialist, they're going in there just with that tunnel vision to that specific need. And so when people are starting to have larger families now, and so they're wanting a family physician that can see all of their generation right there.
Well, And the specialist will tell you, I hide behind my organs, so the cardiologist just wants to deal with your heart, the gastroenterologist just wants to deal with your gut, the urologist just wants to deal with your kidneys and your bladder. They don't want to get into the middle of all the other stuff. You've heard stories, I'm sure, that, patients will ask them about the mole on their side, and it's like, you go talk to your primary care physician about that. And you're right, one of the nice things about being a family physician is you take care of the family. So, patients I have had in my practice for years, I get to know them, some of them better than my own family. And, when they come in, it's always like, so what's been going on? What, where have you been traveling to? What you been doing for fun? And they ask me the same thing. So, there's kind of that interaction that, it's kind of like home week, and you start catching up with each other. And, so when they get sick, then, it starts really pulling on my heartstrings, and you want to find out what's going on with them. So, I think that, I think all physicians are compassionate. I think that, you're right that primary care physicians who see patients on a regular basis, kind of identify with those patients and get to know them, and when something's wrong, they know something's wrong. So my partner, for example, so my practice is, I told you I'm almost 60, and I've inherited practices from a lot of the other physicians that have either passed away or retired or just left Eastern Jackson County. So my practice is an aging practice. If I see a patient under the age of 50 during the course of the day, it's usually more the exception than the rule. But my partner's just the opposite. I mean, he sees lots of kids because he's kind of a kid himself. He's older than I am, but I mean, those kids come in, he moves around them and screams at them, and he gets them all wound up and everything like that. And the reason for that is, if that kid's smiling, he knows they're okay. If a kid comes in and they're not willing to joke around him and mess around him, he knows something's going on with him. So you kind of get to know your patient and what's happening. And I'll sit there and be talking to him, and I can tell that we're not connecting, and you just kind of have to stop and say, what's going on? What am I missing? What am I not doing? Because, they come in, they've got their agenda, they got the things they want to talk to me about. I've got the things that I know I have to address, and sometimes they're not on parallel ground, so you have to back up and either let them get your attention or vice versa. But you actually get to know your patients. So.
And to piggyback off of that, Dr. Williams, we had in the first session earlier, we had an employee share her testimony about she lost her husband suddenly. And the primary question in ER was, who's his primary care physician? And so with that said, do you feel that in today's time, with people choosing to have specialists, and there's multiple ones that they're having for different chronic issues, if they do have a primary care physician, do you feel that you guys are building a connection so that one knows what the right hand is doing, so that if there is an emergency situation of that nature, that how are you connecting with these specialists?
So if you identify that you have a primary care physician, what should happen is, the hospital will identify that person and will send me the records. And, granted, it's a lot better for me if you've gone to Centerpoint, you've gone to Lee Summit, or you've gone to Research, or you've gone to Belton Regional, because that'll automatically get sent. I have more of a challenge getting records from St. Mary's and St. Luke's, but I get them. A lot of times we have to call for them or whatever. But, the specialists individually are better than the hospital doing it. So, if I send Jackie or somebody to, say, a lung doctor, or if I send to a gastroenterologist, we send that referral. That specialist knows to send me a note back. And they're pretty good about it. And we have processes in our office that if we don't hear from them, we call them.
Oh, that's good.
So, that's part of it. But, a lot of the doctors that I a lot of the specialists that I refer to, I know them. I'd send my own family to them. I'd send myself to them. I have. So, you know, I think that's part of it. You get to know who the specialists are. I mean, some of them are physicians who train me, so I have a painful awareness of how good they are or not good they are. That's less so nowadays than it used to be, but you know, surgeons and gastroenterologists and urologists, and, you know, all the ologists that you might need to set people up with. Now it's getting to the point where some of these specialists were my students. They were in his shoes. So, but I know their reputation. I know their skill level. You know, their ethics, that kind of thing. So, and so I can send them to them and get that information back. So Tamika had given me some talking points, which I thought was great. And the first one was why to establish with the PCP. I think we've talked about that already to some degree. You know, you have the biggest thing is continuity of care. So, you know, when you come to a primary care physician, we have your medical records. When you come to see me for the first time, I do what they call a history physical. So I sit down and talk to you, try to find out what kind of health problems you've had in the past. You know, high blood pressure, diabetes, high cholesterol. Find out what your surgical history is. What's in your family history that I need to be aware of that are going to put you at risk for different things. What's in your social history? Do you smoke? Do you drink? Do you do drugs? You know, what kind of risk factors are there? What medications are you on? What allergies do you have? All that information, and then we kind of go through what we call review systems, where I ask you dumb questions about whether you've had chest pain or you've had headaches and that kind of thing. Try to get an idea of what kind of symptoms that you might be dealing with. A lot of them maybe not be the reason that you came in on that particular visit, but they're like, oh yeah, I've had this elbow pain for the last 6 months, or that kind of thing. So, and you're setting up a base of your health care. The other thing that I'm really strong on, that poor Rich here is tired of hearing now, but preventive care. So I want to know when you had if you're old enough. A lot of you guys don't look like you're old enough, but if you've had a colonoscopy, have you had a mammogram, have you had a prostate exam, are you up to date on your immunizations, have you had a tetanus shot in the last 10 years, have you had a pneumonia shot if you smoke, have you had your flu shot yet? Have you all had your flu shots?
They're coming in 2 weeks.
Okay. So, and that's all information that I want to know on the first visit, and if you haven't done it, when we try to get you scheduled for it. So that we're getting that basic preventive care stuff done, because if you can get the basic preventive care stuff done, that's going to, including lab work and that kind of thing, we're going to identify those problems that may be stewing but at a lower level, or maybe they've been existing for a long time if you haven't had a primary care physician. But try to identify those problems early so that we can get them addressed. And then once you've got them addressed, then the risk of them becoming a problem later on is a lot less. That's important because that's going to cut down on your healthcare costs. One of the things that was great a few years ago that's kind of fallen by the wayside now, but all the companies, I'm sure this one did it, would do these wellness visits. So they would give you a break on either your maybe some of your benefits, or the cost of your insurance, or they help out with your glasses or something like that. If you went in and just got some basic lab work and had your blood pressure checked and that kind of thing. And that was great, because what that did was it made people go in and get themselves just a basic checkup. And how many diabetics and people with hypertension, high blood pressure, and high cholesterol were identified just by doing that. And the companies, I'm sure, saved a lot of money on that, because they're identifying that stuff early to get those patients treated. So that guy with high cholesterol wasn't showing up with a heart attack later on, or that person with high blood pressure got that under control and it prevented the stroke later on, or that person that was identified as, they said, went and got their colonoscopy done, didn't show up with colon cancer later on. So the whole reason to get the preventive care stuff done is identifying things early so they don't become a much bigger problem later, but also really cuts down on the cost of health care. So, that person's not showing up in the emergency room with a prolonged hospital stay and critical care and lots of extra costs that are associated with it that MECO's company has to pay out later on and drives up the cost of health care for all the rest of us. Another important reason to have a primary care physician is that you're not that person that's showing up in the emergency room for your day-to-day care. So there's a lot of people that use the emergency room and the urgent care centers for their primary care. Well, if you're going to the emergency room for your primary care visits, that's slowing down everybody else that's also there for potentially more critical care. So, they have to triage people. So one of the rubs that everybody always has is I had to wait so long in the emergency room. Well, if you're coming in for a sore throat and there's a person that's coming in with chest pain, they're going to get priority. Or if somebody comes in with a broken leg or somebody's been in a bad car accident or something like that, they're going to get the attention, and they're going to get the attention of a lot more staff than the triage person who had to look at your sore throat and said, yes, you have a sore throat, we'll get to you as soon as possible. The other thing that happens in the emergency room is they're not doing all that stuff that I talked to you about before. They're getting a basic history. What's your past medical history? What medicines are you on? They'll ask you about your surgeries and that kind of stuff. But they're not going to probably spend the extra time asking you about your immunizations and your colonoscopies and your mammograms and all that kind of stuff. They're going to say you need to go see your primary care physician about that. And they'll try to refer you to a primary care physician if you don't have one already. They'll ask you who your primary care physician is. You said that already. And kind of the same thing happens in the urgent care center. The urgent care center is there for those urgencies, the sore throat on a Saturday night, the twisted ankles, the poison ivy, that kind of thing that, you want to get it taken care of right away, but you don't necessarily want to wait till Monday or 2 or 3 weeks when you can get in to see your primary care physician. But those conditions, while they're important, you need somebody that's going to know you, going to know your history, and is going to still be able to collect all that information from the hospital, from the urgent care center. I mean, we get the information back from the urgent care center. We get the information back from the hospital. And when you come in to see us, so if you're in the hospital for whatever, even if it's just in the emergency room, one of the things that we do is we try to contact you within a couple of days of that visit to get you into our office. And why is that? Well, one primary reason I want to do it is if they change your medicine, I want to know what the medicine change was. Because a lot of the reasons that people end up back in the hospital after they've been in the hospital, what we call readmissions and that kind of thing, is a big problem, because they go in the hospital and for whatever reason they've had several of their medicines changed. And then they get out of the hospital and they don't follow up, and I never know that those medicines were changed, and the patient thinks, well, they changed all these medicines in the hospital, I need to go back and start taking the medicines I was on before I went in the hospital, which is a lot of times that's the reason you went in the hospital in the first place. So, we have to understand why those medicines were changed. A lot of times they're the same medicine, they're just a different formulary than what the hospital was. So, I usually want to try to get those patients back in my office so I can do what they call medication reconciliation, so I know what those medicines are, why they're there, and what that is. So, when is the ideal time to establish with a primary care physician? As soon as possible. When you were kids, your mother tried to get you in the pediatrician, and you went in to get your shots and get your school visits and all that kind of thing. Well, that's important. I think that adults should start having their cholesterol checked around the age of 20. He read a chapter yesterday that said they recommended about 35 for men and 40 for women. I usually try to start doing some of those screenings at even a little bit younger. because we know that cholesterol plaques start building about the age of 15. So, I want to find out, if those problems are already developed and address them sooner than later. But you should start getting, I think you should start getting some basic screenings done, at least about every 5 years when you're about 20, and you should start getting yearly physical when you're about 40. So you should start seeing your physician annually, getting annual blood work done, an annual checkup about the age of 40. If you want to do it sooner than that, that's even better. But I think it's important for adults who are otherwise healthy to start doing it at least at that age. But you should have some established primary care physician so that they have your history, they know what's going on with you, that kind of thing, as soon as possible. What conditions are typically caught early? All kinds of things. Lots of cancers, particularly colon cancer, breast cancer, prostate cancer, a lot of times stomach cancers, skin cancers, uterine cancers, ovarian cancers, cervical cancers, testicular cancers. That's one that you're going to find at a young age. So the highest incidence of testicular cancer starts about the age of 18 and it tapers off after about 35. So, really trying to get younger men to do self-testicle checks at a younger age is important, because that's when you're going to see that. And that's a very preventable type of cancer. If there's one kind of cancer you have to pick, that would be one, because it's very treatable. Thyroid cancer is another one. Just for those types of things. Other conditions, hypertension, obviously, high blood pressure, high cholesterol, just things that we check with the blood test. Diabetes we can pick up pretty easily. Anemias, so if your hemoglobin's low, why is that? Kidney disease, liver disease. Those are things that are picked up pretty regularly just on basic wellness exams. What are the best practices and what makes ours special?
Say because of me.
In this area, well, I'm pretty fond of all. So one of my roles in the center point, I call it facility lead. So I'm basically the physician supervisor for all the employed physicians in the HCA network in the center point market. So Blue Springs, Independence. So I have about 40 physicians that I supervise, and I think they're all good. Primary care practices. So there's our practice, which is Family Care of Eastern Jackson County. We have Family Care of Independence, which is Dr. Jennifer Patterson, Dr. Carmel Carruthers, and Dr. Samir Akhtar. They're over on the Cliffs. Dr. Jason Bergman, who's Valley View, he just took over Dr. Robert and Virginia Robine's practice when they retired. He's in the Blue Ridge Tower building. And he's got 3 nurse practitioners with him. We're trying to find him another physician. There's Centerpoint Physicians Group, which is, they're primarily internal medicine, but they've got Dr. William Andrews and Dr. Kathleen Hong. They're endocrinologists in that group. But there's 4 or 5 in general internal medicine specialists in that group. They're all excellent. I think I might miss it. In Centerpoint Internal Medicine, which is right now Dr. Pam Nabin. So those are our primary care groups. We've lost a lot of primary care groups I think we're the only one in Blue Springs right now. There's Dr. Serafini. I think Dr. Thornton just took over Dr. Stasny's office. So Dr. Thornton used to be out in Oak Grove, that area. And I think they're all decent physicians. In my practice, there's myself, and there's Dr. Bruce Scully, and we have Sarah Dahl, and Dr. Fleming's going to be joining us about the 1st of November. So we'll have actually 3 physicians, and rumor has it that we might get to do another nurse practitioner in here. So there will be 5 providers. I'm only there, right now I'm only there half-time because I'm, in addition to my other roles, I'm also a regional assistant dean at his medical school. So what my job there is to do is to find other physicians like me who are going to allow the students to come in their offices and see patients with them so that they can get the clinical experience. So those of you who don't know about medical school, the first 2 years of medical school is pretty much classroom work. And they're learning medicine. The second 2 years is clinical medicine, so they're actually rotating with family physicians, all the different disciplines. So actually learning the clinical medicine, learning how to put into practice what they learned in the classroom in actual offices. So they actually need offices to go out and practice with. So I've actually had students in my practice ever since I've been in practice in the last 31 years. What makes our practice special? Well, I'm pretty proud of the fact that we have had very little turnover in our practice. We've had, in the last couple of years, we've had a little bit more. That's been more due to retirement than it has been to our employees getting let go or leaving for whatever reason. You know, that happens to some degree no matter what. But, so my nurse has been with me since 2006, and she was with the practice for about 5 years before that. And she used to work for Dr. Bill Cox up in Oak Grove, and was with him for many, many years. So I mean, they're dedicated, they're loyal, and I have to say that probably as many patients come to see me because of her than me. So, you know, I think they're loyal, committed, dedicated staff, and I think that's one thing that's kind of sets our practice apart. They know the patients, like I try to get to know the patients. So when Mrs. Smith calls and is expressing a problem, they know Mrs. Smith needs to get in, and that's hard to do in our practice because our practice is just as bad as everybody else for a new patient or an established patient that's just coming in for routine stuff. We're looking at scheduling November now, but there are times where, you know, I've got to see the doctor. Yeah, we'll get you in. We have to work them in somewhere, but you know, we try to do that. We try to triage and evaluate what's going on, and it helps when we have staff members that actually know who the patient is and what's going on with them, and you know, whether that's somebody that's, you know, is it a lot of drama, or they really got a problem and we need to get them in. So our nurses are all veteran. You know, Dr. Scully's nurse used to be my nurse, and I actually remember when she was an extern, so when she was in her training as a nurse, she worked in my office when I was in Independence. So, you know, she's been around that long. They're committed staff. Our front office staff right now is great. You know, they're all very in tune to what's going on. In fact, one of our receptionists not too long ago, I wrote her up as a commendation because a patient called and was obviously in distress, and she stayed on the phone with her and made sure that, you know, she got help even though we couldn't get her in our office. I mean, she stayed with her and made sure that was taken care of. So, you know, it's that kind of compassion, commitment, and that kind of thing that I think is somewhat special about our practice. DO versus MD. So osteopathic medicine has been around since 1892, and it was started by a medical doctor, an MD, and the reason he started osteopathic medicine was because it was the time of the Civil War, and what he saw as far as treatment was amputations and bloodletting and using leeches and really pretty primitive, barbaric ways of treating people. And he actually lost 3 of his children to meningitis during that period of time. And he thought that, there's a better way to do this. So he started studying anatomy and physiology, and being during the time of the Civil War, he had lots of cadavers to study from. So he's really started studying the human body, and he started noticing things that were kind of in common. One of them was that structure and function were interrelated. So real simple way for me to describe it is you look at your house and you got a foundation. And upon that foundation, you've got your framework built. And in that framework, you've got your wiring and your plumbing that's attached. And then you've got your sheetrock, and you complete the house. Well, if you back a truck into the side of that house and it knocks a wall down, you're going to disrupt your plumbing, you're going to disrupt your wiring, you're going to disrupt the foundation potentially. Well, it's kind of the same thing for the human body. So if you look at the musculoskeletal system, our bones, that's kind of the framework and the foundation of the house. And attached to that is your wiring, your nervous system, your plumbing, your circulatory system, that kind of thing. So if you break a bone, you're potentially going to disrupt the nerves, you're potentially going to disrupt the blood supply. And as he started developing that science, we started noticing things that there are very subtle changes in the musculoskeletal system that help us identify things that are going on in the body. So one of the things that we are really focused on in our training is our palpatory skills. So learning how to touch and feel the skin, and then palpate the deeper tissues and find things that are going on there. A lot of it's just temperature changes. Sometimes it's a part of the body here is sweating and this part's really cold. Sometimes this part's hard. Sometimes this part's tender. And those kind of help us focus on what's going on in the body that might be a little bit different than other places. That's a different tool that we get to use not only in diagnosis, but also we're taught how to treat those areas through soft tissue treatments. And you always hear about people getting adjustments from chiropractors and that kind of thing. We use some of those similar treatments as well, but there's lots more techniques that we have available to us. And what that allows us to do is sometimes we don't have to order that extra blood test, or sometimes we don't have to order that MRI. I always kid around with students. I say, what does MRI stand for?
More
No.
magnetic imaging.
And what did I say it stands for?
More radiologists.
So, if we don't have to order that MRI, what's an MRI run now? $1,800, something like that.
Depends on what body part,
Depends on what it
yeah.
is.
It's crazy. We're taught to try to develop the palpatory findings with our hands. The other thing that allows us to do is I try to shake your hand when I walk in the room. I put my hand on you. I try, I'm a big hugger. I try to have that more appropriate personal contact with the patients, and I'm told that by my patients and my colleagues are told the same thing, that they tend to make that connection a little bit stronger. Doesn't mean MDs do anything wrong. They've been around a lot longer than we have, and their training, like I said, is more academic. It's more kind of body system training. So we'll kind of, and you always hear DOs look at the body as a whole, or they're holistic. I hate the term holistic because every discipline says they're holistic. But we're not necessarily looking at just the shoulder. We're looking at how the pain in the shoulder may be affecting somewhere else. And that doesn't mean that MDs don't do that. Over the last 100 years since we've come into existence, we've kind of come together on a lot of what we understand. So a lot of what we've learned, the MDs want to learn now, and obviously a lot of what they know, we're learning. And there's more and more research going on, and the treatments that we do and the modalities that we use, where there's DOs and MDs in every single specialty in every single state. We work side by side in the hospitals, and you know, if you go up and see a doctor, you may not necessarily know whether they're one or the other. But that's really kind of how we're separate. Do you have anything to add to that? Why did I become a DO? Well, like I said, I wanted to be a family physician. That was how I started out. Never really wanted to be anything else. It was a short period of time when I was in medical school that I thought about cardiology, but I changed my mind. And when I started applying to medical school, I went to my family physician who was an MD, and I said, so where should I apply? And he says, well, and I grew up in Pennsylvania, so he's like, well, Hershey, which is Penn State's medical school, Thomas Jefferson, George Washington. I'm like, Doc, hang on a second. I said, you know, they're already looking at $30,000 tuition there, and this was 1981. And I said, you know, I can't afford that. And he says, have you ever thought about osteopathic medicine? Well, at the time, you know, the tuition was a lot less, even though they were more private schools. And even today, you know, the tuition's a lot more, obviously, but still, relatively speaking, our tuition is pretty, what do I want to say, respectful. But the other thing is, he says, you're not going to get pushed into going into research. You know, they're really just going to teach you they're going to teach you to be a physician. And he pointed me to a physician who was actually a neighbor of mine. He said, you should go talk to Dr. McAndrew, because he's a DO and he can tell you more about it. So I did. And as I learned more and more about osteopathic medicine, I realized that's what I wanted to be. I like the hands-on approach. I like the opportunity to become more involved with my patients, learn about them, not only we talk about mind, body, and spirit, so not only about their health problems, but about them as a person, what makes them tick, what kind of challenges they have, because you all have financial challenges, you all have spiritual challenges, you all have family challenges, and those affect your health. I mean, you know, those affect your blood pressure, those affect your you know, your heart, all those kind of things. So I wanted to be able to work on, you know, all of that, not just look at their blood pressure and say, well, here's this medicine for it. So that's kind of that.
Dr. Williams, if we can use the last 5 minutes to see if there's any questions for you. Do you guys have any questions at all? Anything you want to ask the doctor?
He's not gonna look at that thing on your leg, though. Just saying. Be cool.
These other questions I didn't address.
I think you got through them all, yeah.
If you have any questions that maybe you want to ask him privately, he's available for that as well. But he is in the network, so if you are looking for a primary care physician, we just thank you for taking time out of your schedule.
Right on.
Truly appreciate it. You don't get that much out. You don't get that too much. You know?
Well, thank you all for having me, and appreciate the opportunity.